Okay, so spinal fluid leak management, my favorite topic, obviously. Not one that anybody wants to deal with too much, but a super important one. So, um, of course, my only disclosure is that I personally have never had a spinal fluid leak. That's a joke, but okay. So, obviously, you can have planned durotomies in the context of neoplasia or other reasons to open the dura. And that is sort of its own separate thing in terms of how you close them because you've got very good control and a clean midline opening and closure. But for the most part, what we're dealing with are unplanned durotomies that happen iatrogenically during the case of surgery and are often irregular, can oftentimes be sort of ventral or ventral dorsal and very difficult to access. Um, so incidents, there's not necessarily a consensus and there's some variance in the reporting, but it is common, obviously. And the incidence that you can find in the literature ranges anywhere from 1 to 17%. There's a study out of the UK to try to evaluate dural tears, and it was prospective data. So, relatively good data on about 1,550 cases from 14 different hospitals. Their rates were a little higher than you might expect. It was 3.5% for discectomy, almost 8.5% for stenosis, and then 13% for revision discectomy. I think of note, though, there was a significant amount of variation between some spine surgeons. So, the good news means that a lot of spine surgeons were having these issues less than 8.5% of the time for spinal stenosis. Conversely, some people were having it. Some outliers pretty frequently occur. So I think in that sort of backdrop, it's a good idea to collect your own data. And this is just a image of the Excel spreadsheet that I keep of my case log. And I have a separate complications column for complications. And you may think you're like doing great. Like, oh, I haven't had any complications. I haven't had any complications. And then you can see that, like, I don't know, 2 cases in a row I had dural tears. But at least that way you can look at your own data and you can give your patients like some accurate reporting about how frequent how likely they are to have a CSF leak, as opposed to quoting a study in England that says it's going to happen 10% of the time, and you do a LAMI, and that's not accurate. But if you have your own data, then you can kind of give them more accurate numbers. And I think it's also good to have your own data because someone else is probably collecting it. This study shows like a computer learning model where they actually looked at op report language to identify the incidence of durotomy, which is just kind of a scary thing that they have AI that can do that. And they found that the incidental durotomy rate was about 8.4, actually pretty similar to the study in England. But this was both for LAMIs and for discs. Both those numbers seem really high to me, but maybe they're not. So risk factors, obviously longer surgery, although I don't know that that's a chicken or an egg phenomenon. If you have a CSF leak, it's going to take you longer to fix it. So, but presumably a longer surgery, certainly older age. And this is something that we know very well from cranial surgery. The dura just becomes so much more friable, and it loses a lot of its elasticity and a lot of its strength in older patients. And the same thing is true in spinal dura. So the quality of that tissue is just greatly diminished in older patients. Clearly revision versus index surgery, I think that's probably the greatest risk factor, at least in my hands, because of the scar and the lack of clean planes that can let you kind of get into the dura. And then in cases that start after 4 p.m., which, for obvious reasons, sort of makes sense as well. Things that are not risk factors has nothing to do with whether you're ortho or neuro. They did look at resident and fellow assist figures, and it didn't matter, at least at Hopkins and MGH, if you had a resident. It also didn't matter what level the resident was. So obviously, more experienced residents are going to be maybe less likely to cause the issue. But hopefully that just reflects the fact that those trainees had proper oversight. Mean years as a surgeon since training did not have an impact. So sorry. So, hopefully what that means is more experienced surgeons are more experienced, but younger surgeons are just being more cautious. Then mean BMI did not have an impact. I think if the numbers were large enough or if it was adequately powered, there probably is some association with BMI, just because that makes all technical aspects of surgery more difficult. So I think most of us consider it a minor complication. Certainly, it's a frequent one, and in some ways, it is or can be a minor complication. But it's a pretty frequent cause of medical malpractice. So incidental duodenectomy is the second most frequently named reason for malpractice in lumbar spine surgery, in this study at least. Okay, so what are the consequences? So some of them are obvious. You have a postural headache. The risk for infection, particularly meningitis, goes way up. The risk of new onset neurologic deficit goes up. That's, I think unlikely because of the leakage itself, but perhaps, possibility, root migration out of the sac, etc. Pseudomeningocele formation. And then, as we learned this year, patients can get subdural hematomas or, very, very rarely, but obviously we know they can get cerebellar hemorrhages as well. And in terms of consequences, obviously these folks are going to have worse quality of life outcomes. Their dissatisfaction is going to be significantly higher. I just think about the context of a microdiscectomy where they come in for a 45-minute or an hour-long operation, then leave the hospital 2 hours later, versus having a 2-hour operation, spending all day flat, spending all day the next day flat, and having some headache, and hopefully going home the third day. But it's just a dramatically different experience. So obviously has a huge impact on satisfaction. You can see how upset the Hulk was with laser spine. He was not satisfied. And then it also has a significant impact on cost, as you might expect. So where's that cost increase come from? Well, hospital length of stay. You should put these patients on antibiotics because the risk of infection goes up, at least prophylactically for the first week. And then obviously if they need to go back to the OR, then that's going to increase costs as well. A look at the Medicare insurance database. This is a study. You can see the bottom of the asterisk. It references a study by Yashi and Hassan Sananedi. Sorry for the pronunciation, but it's about $4,000 higher per patient, which increases the cost about 67% to Medicare if they've got a dural leak. And then this Pearl Diver database, which is like a multi-payer private insurance data set, suggests that the actual increase in costs over the global period, the 90-day global period, is about $10,000, which is 120% higher than the cost of a normal surgery for just a lumbar decompression. And then obviously readmission rates are going to be way higher and the hospitalization is going to be higher. So big cost impact. Okay, so obviously, it's going to happen. And yes, it costs more. And yes, it affects satisfaction. But it's going to happen. It's going to happen to all of us. So that's true regardless of your specialty, regardless of your level of experience. It's going to happen to the guys that are going to be out in their first year. And I'm sure it was still even happening to Dr. A and Bob and Greg and me and everyone. And so technically it's a minor complication, but it has some significant ramifications in terms of quality of life, satisfaction, and cost. So management is really critical. And I think the first thing is just like, don't panic, don't freak out. It's okay to get a little bit upset, but you have to really lock in and not sort of start to make rash decisions. And another thing I think that's important, and I think we all know what I mean by this, is, but like, don't pretend it didn't happen. If you see a little CSF leak, or, is it still leaking? Is it still there? Or maybe I didn't really see it. I think most of us know, once we've seen it, it's there, and you have to really kind of explore it and make sure that you fix it, and not kind of pretend that it's not there. So, at least my algorithm, I just cover it with a piece of Duragen or not Duragen, cottonoid or something where I can cover it, make sure there's no, migration of neural tissue or whatever. Just kind of take a deep breath, collect myself. You don't have to say this out loud, but I do think it's important to just remind yourself that the best chance you're going to have to fix it is at the time of the problem. So, just kind of embody that, this is my best chance to fix this, not only for the patient, but for myself as well. And just don't dwell on the problem, just focus on fixing it. So I think Another important thing is that there's no substitute for a good primary closure, meaning actually opposing the dural leaves. I think the second most important point is there's no good substitute for a primary closure. So I think that's actually really critical. So you need to basically optimize your environment to repair the defect. So that sometimes means expanding the incision, increasing bony removal. You really need to be able to see the dural defect, and you need to be able to kind of get around it. In my hands, that pretty much always means the scope. And I have a special set of micro instruments, and Cody and Micah, I think it's probably a good idea for you to also at least know where those instruments are. When you start, are there, is there a Castro Viejo? Is there a dural pickup with teeth? Do you have either Gore-Tex or nylon? Like all the stuff that you need. Make sure that you have those instruments. Even if you're doing a microdisc at a surgery center, you need to have that stuff. And oftentimes, if it's MIS converted to open, I probably convert it to open about 50% of the time. I don't know exactly what my numbers are, but I have a pretty low threshold. At that point, I think the morbidity of MIS versus an open, decompression, which certainly can be debated on its basis alone, is greatly outweighed by the importance of getting a good primary closure. And then in terms of which instruments to use, I think that, that varies a little bit between surgeons. They have looked at this, but most folks use either 4.0, 5.0, or 6.0 stitch. 6.0 is a little bit small for me. I use either 4.0 or 5.0. Gore-Tex and Prolene and Neurolon are non-absorbable. They also have the benefit of the caliber of suture being basically the same as the stitch. So what you don't want is the actual needle being of greater caliber than the stitch, because that's going to create a greater aperture that the stitch will not completely fill. That may allow for some fluid to drain out through the actual hole created by the stitch. And then, in terms of closure of a defect in the context of MIS, thanks, Mel. You just put it down. You can imagine that the challenges of trying to close through that tube are pretty significant. So if you're going to use tubes, you should get these two instruments. The one in the upper right-hand corner is basically an extended needle driver, and it has a little bit of a bend there, so you can actually throw a stitch in the tube. And then the lower image is a knot pusher. So it's pretty technically difficult, but it can be done. And some people would argue like the potential space being lower because of a tube being used can help improve recovery from a CSF leak. So, I was just at this LB conference this week, and there was actually a debate on this, and some of the MIS guys were suggesting that they could be really kind of aggressive and even send people home the same day sometimes, because look, if you have a CSF leak through a small tube, there's no potential space, and the problem is not going to become an issue. There may be some merit in that, but I essentially would treat a CSF leak created through a tube the same as I would through an open surgery, and I just kind of disagreed with that whole philosophy. But there may be some merit to it, having less potential space. In terms of what you use, this is Paul McCormick, who was one of my mentors at Columbia, and he did a tremendous number of intradural tumors, and so I just kind of learned to deal with the dura through, watching him. He always used silk, which is not, I think, probably the most commonly used stitch, and probably not the one that most people would recommend, but I do really like it just because of its handling properties. It's super easy to tie. It's super easy to sort of get a good knots thrown down long tubes in particular. But it's hard to find the right needle on a silk stitch. So just get a sense of what works best for you guys. One thing, I've never used this, so again, disclosure, but it is kind of interesting. We're trying to get it approved right now. There's this device called Durastat, which has basically these two long sort of bayoneted tips, and you can see what the edge looks like. There's a little video, if I can get it to play. Can you guys see this video? Anyone?
Yes. Yeah,
Yeah,
we can.
yep,
It's playing.
So again, I've used this on a sawbone dural type model. But basically it has this little like trigger, and then it loads it with a spring. And then once you get it down to sort of the dural edge, you can kind of like grab it a little bit, and then it's spring loaded, and you just release the spring and it shoots the needle. So it's kind of a cool concept because then you don't have to manipulate the dura very much, and you can actually throw like a hyperangulated stitch with some velocity to kind of penetrate the dura. Um, it's expensive and it may not work as well as this sort of video suggests, but it is at least intuitively a very good idea, I think. Now for the model case that they're showing, I mean, that's kind of like the case where you wouldn't need it, right? It's like right in the middle of your tube. I think in that case, you can just use a Castro or like a long MIS needle driver. But if you have a stitch, or excuse me, if you have a defect that's like lateral by the root or something like that, I can see that this would really come in handy. And then that's a knot pusher. You should have one of those regardless of whether or not you're using this device. They make those instruments as well. You can get it in a metal from a company called Surgalign if you're going to use tubes to do decompressions. Okay, so there's also some literature about using these titanium clips, and there's a study that shows that they are like technically stronger than the stitch, but I think that they're also technically quite a bit more difficult. So I've not adapted those. And then there's a variety of sealants. So this was another thing that interestingly was talked about a bunch this weekend, and I think people have varying levels of confidence in the sealants. I'll disclose I don't have a ton of confidence in the sealants, but in terms of what's being used currently, the most common technique was a combo of primary closure with some kind of patch like Duragen and then a sealant. After that, people would use the primary closure and the patch, and then just the primary closure. So people are using sealants quite a bit. That did show some evidence, or using the like Duragen graft did seem to reduce the rate of recurrent leakage, but sealants did not. So there's not good data, at least from this study. I don't know if anybody else has looked at it, but this is a recent study from 2021. So there's no real good clinical data that using sealants actually reduces the likelihood of recurrence of the leak. It also doesn't appear to affect infection or neurologic function. And then there's like a host of different strategies of, like how do you use the sealant and the Duragen? Do you put the glue down and then the Duragen and then the glue again? Or do you put the Duragen down first and then the glue? Do you use the sandwich technique? It's the chicken or the egg. There's lots of different strategies. I think I've tried them all. I don't know that one necessarily is better than the other. If I don't feel like I've got like a watertight closure, there's some issue with the closure, I'll probably put a little bit of glue on it and then of Duragen and then more glue around the edges of the Duragen. That has in no way been bulletproof for me, but intuitively it kind of seems to make the most sense. The one that we use at Scripps is Duraseal. Some folks prefer Tisseal. Like my partner Chris Uchiyama prefers Tisseal. That may be better, even though it's not specifically designed for dural leaks. So just keep an open mind. One thing that I did not learn in training, but I've learned in practice, mostly from my partners, is how useful fat can be. Most of my experience has been in the posterior sort of pseudomeningocele space. So when you do like a fourth ventricular tumor or anything in the posterior fossa, a pseudomeningocele or sort of like a expansion of the CSF space is a classic complication. As you can see, that's a dependent part of the wound and a dependent part of the CSF space. And so it's very common to have these pseudomeningoceles form, and they can create chemical meningitis and a whole host of difficult problems. And one of the things my partners do is they actually take a fat graft from the buttock or from the back, wherever they can get it most, with the lowest amount of morbidity. And then they pack that space with fat, which when I first heard it, I was like, well, that doesn't make any, that's crazy. But it actually works really well. And I don't know what it is about fat, but it kind of like releases this serous discharge. And I think it helps with scarring and really helps seal the leak, in addition to the obvious impact of just filling the potential space. So I kind of, if there's a challenging leak, I'll always use fat. Sometimes if there's like a bad leak from some of our partners who will do operations in the emergency setting, they then end up in my clinic afterwards for insurance reasons. And so I've had a couple challenging ones of these pseudomeningocele cases, and I've used fat with some success. And then I like to leave a drain. So obviously you don't want to leave a drain on suction because that's going to create a vacuum. It's going to potentiate any defects and and drain CSF, and it can even be done in a dangerous way. So why leave it drain? Well, I like to just have something in there to collect any standing fluid. So I either have it on gravity or clamped, but I do like to have a drain in place just in case a fluid collection is building. It can also give you information about the leak. Like if somebody kind of gets up and walks, they feel okay, you have a Hemovac clamped, you can then just put them back in bed and open the Hemovac and just to gravity. And if a bunch of fluid starts coming out, even though they're symptomatically okay, you might know then that they still have a leak. And then it protects against the one-way valve effect. So what I mean by that is oftentimes if there's a dural defect, that CSF fluid can get out, but once it's out, it's obviously not getting back in. And so it can create like a pressurized, it can create a pressurized fluid collection, and that can cause radiculopathy and problems. And so if you have a Hemovac, you can always open it to gravity and relieve any pressure symptom that's there. And then the flat protocol. So I have people flat always for the day of surgery and the next day, sort of regardless of circumstance. Whether they stay flat, so say postoperative day 1, they're flat, postoperative day 0, they're flat. Whether or not they're flat postoperative day 2 is a bit of a debate. Are they having any symptoms? Are they having headache when they're flat? Do they have a spinal drain in? So, it's not a one size fits all thing. But I do think that the flat protocol is important. I think everybody does it for lumbar spine surgery. I know some folks in cervical spine don't. At least the way I was taught. I mean, I would understand the rationale for not keeping cervical folks flat if the water column was below the site of their injury, but the water column is all the way into the ventricular system, and so the water column is still above the site of their injury, and that's why I think it's still preferential to have them lie flat, even if it's a cervical injury. And then when to place a lumbar drain. I think there are, I think very few, if any, instances where I regret placing a lumbar drain. But I think my rule of thumb, at least, is if I'm kind of on the fence, or if I think there's any evidence that, even though I did the best repair I could, there's still some leakage going on, then I place a lumbar drain. And it's like the easiest thing to do. That hopefully the fellows have all done it with me or a couple of times in the OR. Use fluoro. You can put them in the lateral decubitus position if you want, but I think if you have this problem in the OR, then they should just be prone on the Wilson. You want to go to the side of your incision, obviously, if you're doing it at the index operation. If you're doing it separately, then you can probably just do a conscious sedation, and you can do it either in lateral decube or prone. But I like prone because you can use fluoro, and that generally just means it's one stick with the needle, which just makes it a lot more humane. I usually go for 3-4, but depending on where the index operation was, that may change. Obviously, if the surgery was at 3-4, then I would probably go below that. If the surgery is at 4-5, I would probably go 2-3. Just so I have some room. But obviously, you want to be going 2-3 or lower, and 3-4 is sort of the sweet spot. And just check their MRI. Is it possible they have a low-lying conus? It's possible. Pretty uncommon at 2-3 though, to be getting in the area of the conus. But just check the MRI to be sure. And 3-4 is sort of the sweet spot, but certainly you can do it lower. And this is just sort of a picture of the spinal drain going in and all the supplies that you would need. So my protocol usually is 2 to 3 days. I guess it's probably more often 2 days and not 3 days. I do let them get up, for meals into the bathroom. The spinal drain obviously has to be clamped when that occurs. My rate is 12 cc's every 2 hours. That is not literature based. That's just from my mentors, what I've sort of observed and does appear to be effective. Some people will try to make it continuous. So they like raise and lower the bed to try to get like a certain number of cc's off every hour, 2 hours. That essentially requires like one-to-one nursing. And I don't know that continuous drainage is necessary. I mean, I think the argument is that then there's always a pressure valve, and pressure never builds up in the fecal sac. However, if you're draining 12 cc's every 2 hours, the pressure is going to, be dramatically reduced in the fecal sac, and it's a lot easier on the nursing staff. These Limitor systems are greatly helpful because if there's a nurse that's maybe not as familiar with spinal drains, or say they get called to a code or something like that, and they leave the spinal drain on, that could obviously be a very dangerous situation. And so Cody and Mike, I think it's important to try to make sure that you have this collection system as well. It's called a Limitor. And basically it will not allow for more than 20 cc's of fluid to be drained off as a sort of pressure valve here that'll prevent additional drainage. And obviously that's a great safety mechanism. So that's kind of all I have. I mean, it's one of those things where unfortunately it's going to happen to you, and you'll learn what you like best and what works best for you once you're out in practice. But we are always here to help. I mean, I'm sure like Bob and Greg get all the cool questions from our former fellows, like, "Hey, I've got this like awesome deformity. Like, should I do a PCO or what?" I often get called about CSF leaks, which are a little less awesome. But I am always here, as you know, all the fellowship folks are, to kind of talk about a case and what you should do and how to manage it if you need to.